Good evening, friends. Welcome all. This is
Recording has started.
This is the idea of Mohan, which we are planning to do some webinar series of mainly focusing TAVI and imaging. In the first series, we'll just start with the basics, and I'll first introduce all panelists. Dr. Mohan, who you all know, Dr. John Jose from CMC Veller, Dr. Sundar from Kaveri, hello, and Dr. Shivakumar from Madurai Meenakshi. We have two excellent topics today, and they're both very interesting ones. And the first one is Dr. Syed is going to talk about transcatheter aortic valve implantation. I need to introduce Dr. Syed. He's excellent guy to start with. Never mind how good he is in the profession, but he's excellent guy, and he's got excellent hands. And he makes it's nice to it's lovely to watch him doing TAVI. He does so simply, and he said, "Oh, TAVI is so simple." But behind the simplicity, he has gone to so much routine work and methodological preparation of the patient's individual idea, and finally come to one protocol, and he sticks to it, and it looks very sleek when he does it. He does approximately 12 TAVIs in a week, and he uses both balloon expandable and self-expanding, so which is very interesting with him, because he individualizes each patient and choose which is best for that patient, and that's very unique of him, and it's a big honor for us to have Syed, Dr. Ghostini. Welcome, sir.
Hello.
And next one will be Dr. Vijay Kumar. You all know Dr. Vijay Kumar, and he's our imaging guy. He's he is one of our gift to Tamil Nadu and India, maybe, because he's such a talented man who he's like kind of he loves imaging. He's just imaging man. You can just say imaging and Vijay Kumar are just not separable. And he's going to talk about basics of OCT. And because we will have to go on time, what I'll do is I'll get Dr. Syed to go ahead, and then we will have his talk, and then we'll have question and answers for TAVI at the end of his talk, and then we'll have the next talk. So that's the schedule today. And with the questions and things, what we'll do is we'll have it towards the end of the presentation. Unless it's a very burning thing, we can add it before, or we can have it towards the end, which will be good to have discussion. And you can have many questions to Dr. Ghostini, and he'll be very happy to answer all your questions. And welcome, Dr. Ghostini. Please take over the slides, please.
Thank you, Dr. Savanan. Dr. Mohan, Dr. Sundar, I'm very pleased to be with you today, and I'm honored to be here to talk with you about TAVI and on this webinar. Well, let's say that you will have my topic will be a 75-year-old patient with symptomatic aortic stenosis addressed to your hospital. And we will talk how to manage this patient in 5 steps. So the first step would be the heart team decision, the risk stratification, comorbidity, and frailty. The ESC recommendation are about 2017, and the ESC talk about, patient that would be favored for TAVI and patient would be favored for aortic replacement. So for aortic replacement, you have always the patient with the logistic Euroscore would be a low risk patient, youngest patient about less than 75 years old, and suspicion of endocarditis. Okay, all other presentation would be suitable for TAVI. And in 2019, we have 2 trials. The Partner 3 trial, which showed that a patient that would be treated with the SAPIEN 3 valve have better outcomes than patient referred for surgery. And the Evolute low risk showed that TAVI with self-expandable would be equivalent for surgery. Here, this is the slides for Partner 3 trial, and you see the primary endpoint was better with TAVI than surgery, and this is for superiority, okay? But please check for both trials the key exclusion criteria, okay? They excluded the patient would have small annulus and large annulus, less than 16 or more than 28, bicuspid valve, severe aortic regurgitation, severe left ventricle dysfunction, and complex coronary artery disease. Okay, this is the same criteria for the Evolute R low risk trial. Okay, you have the same contraindication. So if you have patient referred for your institution, you have to check that even if he has low risk or intermediate risk, please discuss with your heart team, with your surgeon, if he has these exclusion criteria, because there's not only the risk stratification. You have to see what your trials showed. And nowadays we have this classification of the valve. You have the intra-annular valve, which includes Santira, Lotus, and Portico, the accurate Symetis, and the core valve. And here you have more bovine pericardium in Edwards, Lotus, Portico, and porcine bovine pericardium, for the core valve and Symetis. In France, we have three reimbursed valves: the SAPIEN 3, the Evolute R, the Evolute Pro, and the Symetis since 1 year. Okay, the Lotus now they stopped the marketing as also for direct flow, and we are waiting for the reimbursement of the Portico in few months. Check that the catheter was miniaturized. In the beginning, with 2002, I began the TAVI in 2008, and we had always the femoral approach were done by surgery. We had a 22 French sheath. So with 22 French sheath, we needed the surgeon to do the approach of the femoral artery. And in 2009, we had the 16 French, and now we are about 14 French for the SAPIEN 3. This is the SAPIEN 3 with the valve that they had the fourth generation of SAPIEN, because before we had the SAPIEN XT, they added an outer skirt here to reduce the paravalvular leak. Okay? And they improved the alignment with the retroflex, which goes until 120 degrees. And you have a fine control the valve positioning in the annulus. Okay, you have four diameter, 20 millimeter, 23, 26, and 29. And check that the 29 millimeter valve would be on 16 French sheath. This is the core valve Evolute R, and the Evolute R would be a self-expandable valve. It is a porcine supraannular valve, and now we're using 14 French sheath, so you can use it on if you have a femoral artery diameter more than 5 or 5.5 millimeter. It's a totally recapturable valve, which differs from the first generation of core valve. And now we are using more and more the Evolute Pro, which had a skirt outside the stent until 13 millimeter, which can reduce the paravalvular leak and the aggression on damage on the annulus. So these are the valves available in France. But before going to the cath lab, half of the work would be done before with the CT analysis. Okay, Now the patient are referred for the heart team, and you know, for a 75 or 73-year-old, if he has a favorable anatomy, he would have TAVI procedure, okay? And if the CT analysis show that the patient have anatomy with very calcified annulus and anatomy, and if the femoral are not very good, so the patient would be referred for surgery. We had before the patient referred for the surgeon, and then the surgeon will discuss with the heart team if the patient is old, and then referred for TAVI. Now everything is going very quickly and very different. We have the patient referred for the heart team, and he will go directly for the TAVI, and if the anatomy is not favorable, so he'd be referred for the surgeon, okay? And the CT analysis would measure the annulus, would check which valve would be suitable for the patient. You know, if you have experience with one valve, sometimes this valve that you are have, it would not be suitable for your patient if he has a small annulus or very large annulus or some calcified on the annulus. So you have to, you will begin with one valve, and slowly you will have to have the experience with the other valves. CT will give you the coplanar view and would give you the TAVI accesses. Okay, so this is the valve sizing would be done on the hinge point of your annulus, and you would be measure the area to choose the Sapien 3 valve, and you will check the perimeter for the self-expandable valve. Okay, so how do you use it? You will check perpendicularity on your annulus. Okay, and then you will measure your annulus just below your valsalva. Okay, please don't do fluoroscopy for your patient to check the coplanar view. The CT scan will give you coplanar view when you check perpendicularity. So here, this is an example. You check perpendicularity on both view, and you will measure your annulus here, a little bit below your valsalva. Okay, you will draw a line, a circle, and it would give you the diameter 21.9. Or an area. This is the diameter derived from the area for the Sapien 3, and you will use the diameter derived from the perimeter for the Evolute R or Evolute Pro. Okay, and then you will have this table that will give you, according to the area, the valve that you have to choose for the Sapien 3, and this is for the Evolute R, Evolute Pro. You will check the diameter derived from the perimeter, okay, and then you will check for both valves the high of your left main or right coronary artery and the larger of your valsalva, okay, because you can experience in some cases a coronary occlusion. CT will give you also the level of your puncture of your artery and the diameter of your femoral common artery if you want to puncture it on fluoro, if you don't want to do it on echo. Be careful, sometimes you have artifacts, and artifacts would be very complicated sometimes you have to do another acquisition for you to check the annulus, because you cannot in some cases correctly measure your annulus. Beware also some calcified nodule here at 4 o'clock. Okay, this calcification could have after your valve implantation could give you annulus rupture, and sometimes in this case I prefer use a more self-expandable valve than balloon expandable valve. Step 3, now you have your CT, you checked everything on your CT. So your procedure is already planned. Okay. In 95% of the case, you will use the transfemoral artery, and in 5% of your cases, you can use axillary or transapical. In our alternative approach for the transfemoral would always be transcarotid. So this is TAVI in France, published last year, and more than 91% of the procedure were transfemoral. You see, the transapical, transaortic were less than 2 or 4% of the procedure. So you have to check that your minimal femoral diameter would be more than 5.5 millimeter. Your ischies for SAPIEN 3 would be 14 French for the 26 millimeter, and would be 16 French for the 29. Your SAPIEN 3 would be crimped on the catheter proximally to the balloon, and you have to align the valve or the balloon on the valve by pulling the balloon in the descending aorta. So you decided, you choose your valve, and now you want to do the transfemoral approach. You have to have your lot of experience with the ProGlide suture mediated closure system. Okay, it's very simple. So if every time that you can use it for transfemoral artery, if you do PCI or transfemoral, if you don't have your transradial approach, please use the same system, because you have more experience with the ProGlide. You have 4 steps the first one, you will open the foot, then you will depress the needle, then you pull back the needle, and then you will close the foot and take back the suture, and then you will lock it. Okay? And because you are closing more than 12 French puncture, you have to use 2 ProGlides. It will give you more security. The first one you will put it at 10 o'clock, and the second one you will rotate it 30 degrees or 15 degrees. You will put it on 2 o'clock, and you will close them. It's a pre-closing. You will put them before, and you will close them at the end of the procedure. Okay. So let's check how we aligned a SAPIEN 3 in the descending aorta. You see here, we are pulling the balloon back in the valve. Okay, next step, you will go crossing the arch, and you will do what we say, the retroflex in the arch. And please here, you see that the arch is very calcified, so you have to pull a little bit on your stiff wire to let the nose of the valve don't go and touch a lot the descalcification. Okay? Then you will cross the calcified valve, and then you will do the rapid pacing and deploy the valve. Sometimes you can deploy it in very quickly. I prefer to deploy it very slowly. Okay? And then you check that you don't have aortic rupture, leak, or coronary occlusion. And this is the deployment of the Evolute R. This is the first deployment with always angio during the deployment. This is the correct deployment. The valve, the stent is about 2 to 6 millimeter in the annulus. This is the final release. And this is the result. Like Saravanan told you, it should be simple. It should be simple. So why it should be simple? Because my boss told me that every procedure that would be more than 1 hour, it's a complicated procedure. So you have to work not quickly. You have to prepare your procedure and to check everything. You have to deal with complications. Complications are, you'll have them every time, but you have to deal with complication. Sometimes femoral access is impossible in 5% of the cases now. So you have apical access. The apical access is reserved for the Sapien 3, and the aortic access would be done both with Evolute or Sapien 3 valve. You have to check only something with the aortic access, that your puncture in the aorta should be more than 6 centimeters from the annulus. Why? Because if you want to release an Evolute or a core valve, you have to check that you have more than 6 centimeters, because the capsule would goes up to release the valve. And with your Edwards, you have the same thing with the balloon. Your balloon would be about 4 centimeters, so you have to check 2 centimeters more than your balloon length. Subclavian, I will be very quickly, it's only for core valve. And now we are using more and more transcarotid access. It would be the common carotid that we check on CT. And we have, when we do our CT, we check everything from the carotid until the femoral in the same exam. Now you are doing your procedure. Your help would be hemodynamic monitoring. You see, hemodynamic would give you, yes, I know, the aortic stenosis diagnosis, but when the patient is referred, he did have echo, and the diagnosis is good. It could give you differential diagnosis, but it would be very helpful to evaluate the good results, to detect the aortic regurgitation and especially complication, because when you will have complication, the patient would have hemodynamic damage. Okay? If you will use the balloon expandable, you have to check that your ventricle pacing would be good enough, and to ensure one-to-one capture. Because if you have this rapid pacing, when you are opening or inflating your balloon, you can have a migration of your valve. So you have to check that your ventricular pacing is good along 2 to 3 seconds. This is we don't cross the valve after the deployment. We do only aorta injection to check if you have paravalvular leak or not. But hemodynamic, the measurement of your diastolic pressure would give you always the good results. If you begin your procedure with a diastolic about 60 millimeter, and at the final of your procedure you have a diastolic about 80, so I think you don't have paravalvular leak. But if the patient have 80 millimeter diastolic pressure before, and in the end of the procedure you have 40 millimeters, so I think you have a good paravalvular leak. Well, I don't use the aortic regurg index. It's too complicated to do it on during the procedure. You see, that's what I told you. If you have here 35 millimeter diastolic pressure, well, do balloon valvuloplasty, and when you have this is an aortic regurg type 3, and after balloon, no regurg. So the diastolic pressure will always give you could be helpful to help you to do balloon valvuloplasty or not. And I think you cannot if you want to go to the intermediate or low risk patients, you should not have a paravalvular leak more than grade 1. And when you will have complications, it would come very quickly after the release of the valve. This is a ventricular fibrillation or tachycardia. And when you check angio, you see you lost your left main. So you have your left main occluded by the native valve. So here you have to go quickly and open the left main. And sometimes you have circulatory shock, and when you do your angio, you see that you have annulus rupture or vascular bleeding or tamponade. So hemodynamic monitoring during the TAVI is very helpful to detect your complication, and you don't have to lose time to repair. Step 5, you have to deal with vascular complication. Okay. When we do TAVI, we have to puncture on the common femoral axis. So here, after the TAVI, we have, you see here, we have bleeding. So very, in 15% of the case, we have to do crossover and put either a balloon or covered stent. And sometimes it's only if you do your balloon valvuloplasty, okay, you could have good results. So try balloon valvuloplasty, and if needed, you can do covered stent. Use the crossover material. Well, use always the ultraflow. It's a 4 French catheter. We cross the wire and we put either with Terumo or 0.35 inch wire, and we change to the guiding wire of Rosen manufactured by Cook. We put a destination 55 centimeter sheath according to the diameter of the stent that you have to use, either 6 or 7 French sheath. We use the Mustang balloon, and in our cath lab we have the big raft from Bentley that they give us very good results as a covered stent. So it's my last slide, and I think I respect the 30 minutes. TAVI, it's a great French invention. It has done major technological improvement. It's safe and reliable, but you have to pass the learning curve, okay? And when you begin TAVI, you will have always probably a proctoring, but you need a heart team because you cannot do the procedure alone. Please check that your surgeon would be with you to help you if you have vascular damage or annulus rupture, okay? And I tell you this because in our institution we've done more than 1,800 procedure since more than 10 years, and I know what I mean. You cannot do the procedure without surgeon. So please let the heart team be very good, because you will have the patient that the surgeon will not want to operate, and you will give for the surgeon the patient that you think would be at high risk if you do TAVI for them. Thank you for your attention.
Thank you, Syed. That was a very nice presentation. The learning curve, what do you say? How many do you think we should start?
Well, it's sometimes yes, it's very difficult to answer to this question, but I think the learning curve you can you need a 20 valve per 20 20 valve. For each procedure, you can do, if you do 20 procedure with the Edwards or 20 procedure with other valve, I think you'd be very, very good enough to. The problem is that you'll have to experience all the complication, so vascular complication, you will have them either with balloon expandable or self-expandable. So you have to deal with complication. The procedure would be very simple if you planned your procedure. And I think you will have proctoring for the 21st procedures.
I mean, people who are not seen side working, like, is so meticulous. He does every single thing very carefully checking. If he is measuring a 6 millimeter femoral artery, he will have, when you're doing a procedure, he'll have a 6 millimeter cover stent, balloon, everything ready. So you expect every single complication, and he goes for it. And like I said, it's just like a routine PCI, like type A PCI. That's the way he does it. And he has gone through a lot of experience over the years. And for us, it's easy to learn from his experience and take it, which is more safe, and go for it. And,
yes, yesterday I was talking with my colleague, Dr. Fradi. He told me you are now more comfortable with TAVI than with PCI.
Yes, like that.
Yes, but I think it's like the bicycle. Even if you stop 10 years, when you go back on the bicycle, it would be very simple. The difference between TAVI and PCI is that you have to be careful for your CT scan, and you have to check your CT scan even before beginning the procedure. Sometimes you measure the annulus and you measure your femoral artery 1 week or 1 month before. But you have to check your CT scan just before beginning the procedure, because you have everything on CT. Okay? If you want to do balloon valvuloplasty, you have to do the balloon valvuloplasty according to the annulus diameter. If you want to do as you said, put a cover stent, you have to choose the cover stent according to the femoral diameter. So if you prepared everything before, yes, it would be very simple.
And even we could able to still remember that even the previous day when you have showed us the case and you had told us to measure everything, even just prior to the to do it a mismatch case assessment, and now.
Yeah. I didn't understand the last question, Manny, because you don't have. I don't have good connection. Yes, even before beginning the case, you have to check another time the CT and what you are doing. And sometimes you ask your colleague, surgeon or cardiologist, what he prefers. Sometimes he would be preferred this or this valve. You have to check everything with and to deal with the heart team. The heart team is here to to protect you and protect the patient. TAVI, it's not a two hands work; it's a four hands work. You are two operators usually. So you have to work with the same person. If you want to deploy the valve, you have to tell him, well, deploy very slowly or quickly. You have to be aware that your nurse that will do the rapid pacing understand your vocabulary. If I had this once, I said pacing on. Okay, so she did the rapid pacing, and then I told my colleague stop, and she stopped the rapid pacing. in our experience, the nurse will stop the rapid pacing when we say pacing off. Okay? Pacing on, pacing off. So if you have another nurse would begin the experience in the TAVI program and stop the pacing before the deployment of the valve will embolize.
Said, there we've got a good question.
I think
saying which valve? You get the question as well. The valve pacemaker is high, and what are the complications for patient who needs post TAVI patients pacing rates? I think that's the first question. What rate do you go for? What rate do you go for balloon expandable? What's the rate of your pacemaker rate? And do you always use pacemaker for self-expanding as well? I think that's what they're trying to mean.
Yeah, the rate of pacemaker with the balloon expandable is about 8 to 10%. Okay, and we have 15 or 18% need to pacemaker with the self-expandable. And you know, when we have patients with the right bundle branch block and BAV1, sometimes we know that these patients will have a complete block. So in these patients, we can put pacemaker previously to the procedure.
And another interesting question from Dr. Satyamurthy. Is it possible to make out whether it's a bicuspid valve or tricuspid valve in a heavily calcified valve?
Yeah.
How can you make it out? Because the valve is fully, whether it's calcified, how can you differentiate when you see it's very, very calcified?
Okay, so these are not basics of TAVI. We are not in the...
No, one of the selective...
It would be a discussion. In bicuspid valve, usually, yes, with bicuspid valve, you have to go very, how to say, with very caution, you know. With bicuspid valve, well, I prefer put a balloon expandable valve, because you will not, with a self-expandable valve, you will not have enough radial force to push the native valves. Okay, the problem with the bicuspid valve is that you can experience annulus rupture. So if the patient is young, because it's bicuspid, please refer the patient for the surgeon. If the patient is at high risk of surgery, you can do, I prefer do Edwards implantation in bicuspid but every patient is different. I prefer check the CT scan to see if the calcification are only on the valves or in the annulus. If calcification are only on the valves, you know, you don't have a lot of risk of annulus rupture. If the calcification are more in the annulus, you could experience annular rupture. So you see, in this case, I don't. Do you see my slide here?
Yeah, we can see it.
Yes.
Do you see the slide?
Yeah.
Okay. You see this calcification here? It's like a nodule here at 4 o'clock. Okay. It's always this calcification that rupture your annulus. You see here under the left main, you don't have a structure, heart structure. So when you push with your balloon, okay, your calcification will rupture your balloon here. So if your bicuspid is only calcified on the cusps, it would be feasible with TAVI.
Jose, you wanted to tell something? Yeah, so Dr. Syed, Dr. Syed, that was a great presentation on the basics of TAVI. So I just want to ask you a couple of questions. Like many of the audience here would be like beginners for TAVI. So other than bicuspid and like say presence of calcification, are there any groups where you would have preference for a balloon expandable or a self-expanding valve, right? Most of the centers here are low volume centers, TAVI centers. So like when you're starting to do with TAVI, would you advise to choose a particular valve? Say like start with a self-expanding valve, or do you recommend mix of both valves based on the anatomy?
Well, yes, yeah. If you have small volume center, you have to begin with one valve. And if the I could do another presentation. I don't have it here, but usually you can, with a one valve you can treat, I think, more than 80% of your patients. You know, but sometimes you have very big annulus. With big annulus, especially if they are calcified, it would be more suitable for the Sapien 3, 29 Sapien 3. If you have valve not very calcified, and especially if your annulus is small, about 20-21 millimeter in very old lady, it would be more suitable for the self-expandable. If you have a small annulus with the self-expandable, you will have less mismatch than with the balloon expandable. If you have redo procedure for valve in valve, it would be very simple with the self-expandable valve in your bioprosthesis. If you have very calcified valves, it would be more suitable for Edwards valve. You see, you have lot of situation, but I think if you have the experience with one valve, you can treat more than 80% of your patients. Okay.
So this coming back to Dr. Sathimurthy's question on detection of bicuspid valves, I think if you use a transthoracic echo, your sensitivity is as low as 60%. So you need a modality like CT or a transesophageal echo to diagnose bicuspid valves.
Yes, you need always CT before proceeding for TAVI procedure. Always.
Can I have
because you have to check perpendicularity. Yes, I'm sorry. Excuse me.
This is Shiva. You said if you adopt yourself to one valve, 80% of the time you can get away. For example, in my case, if I say I am comfortable with the Indian S3 called as my valve, where I should not do balloon expandable valve. If I am in that process of getting adapted to one particular valve that is balloon expandable, where should I avoid doing this balloon expandable valve? In which conditions I should avoid this?
With the balloon expandable?
Yes.
Yes, you know, sometimes you have aortic stenosis without very amount of calcification on your valve. If your valve is not very calcified, if you put a balloon expandable, it could embolize. You could have migration of the valve. Okay. Sometimes you have more aortic regurg and a little bit of stenosis. So if your valve is not very calcified, well, even if with your balloon expandable, you could have migration. If you have a very calcified annulus, like I showed you with this some calcified in your annulus, you could have an annulus rupture. When you treat valve in valve procedure, you know, if you have a 23, let's say, Perimont or Sapien or Edwards or something like this, for valve in valve procedure, you can have more mismatch with the balloon expandable valve. This situation will let you go to the other valve with the self-expandable, because sometimes you cannot have 100% of procedure done with one valve. So unless you will refer your patient for another doctor or another team, unless you have experience with the other valve.
When there is no calcium, when there is severe AR, when there is valve in valve situation, I'll try
Yeah.
to avoid balloon expandable. Okay, great.
Yeah.
Jose, you wanted to add anything more than this? Because you have a great experience with this balloon expandable system, which is more adaptable to our part of the world because of the cost and other issues. Do you want to add anything?
Yeah. So in my practice, if there is a lot of LVOT calcium, like the case which Syed showed, such cases I would avoid balloon expandable valves. And like you said, if you have a very small annulus diameter, like your annulus is about 18 or so, those cases I would probably prefer a self-expanding technology. So otherwise, the other cases I would kind of discuss case by case and choose the valve. In our setting, we do get a lot of rheumatic valvular heart disease patients, some of them who have previously had a mitral prosthesis. In such settings, probably I would prefer a balloon expandable valve because you could have problems using a self-expanding valve.
Yes, also if you have renal damage, and in all the trials they said that with the self-expandable you can use more iodine. So if you want to use less iodine, you can go to the balloon expandable also.
So
and if you have a young patient, and probably if you don't want to experience a pacemaker after the TAVI, okay, you can do also balloon expandable, because you have less pacemaker need with the balloon expandable than the self-expandable.
Less AKA, less pacemaker. Excellent.
There is
So
one
the
question. What was the
And there is one more question which has been.
What was the hemodynamic monitoring point you were saying about during AR? How do you quantify AR? You already mentioned that in the slide. How much when do you decide to do a paravalvular leak, to fix a paravalvular leak and not to fix a paravalvular leak? I think Dr. Vivek wanted to know it again.
Yeah, you should not have paravalvular leak after your TAVI. Okay? So everything should be done to not have a paravalvular leak. And if you have paravalvular leak, you can check it by angio, and you can check it by echo. And if you have if you will discuss with your echographer the need to balloon valvuloplasty, so do it. If you're not sure that you have a good result, it means that you don't have a good result. So if you discuss it with your echocardiographer, so you have a paravalvular leak and you have to do balloon valvuloplasty to have a minor leak.
There's one question.
If you have good results from the beginning, you don't have to discuss with your echocardiographer.
There's one question about what is your long-term results or success rate on TAVI? What is success rate first, and what's the long-term success rate? Immediate success, long-term success.
Well, it's difficult to answer, but
But of a simple thing, he's very modest. But when I asked about complication, he has to think about complication when he has to chase some time ago to look at complication. That's his success rate.
Yes.
Because, that's the way. Because it's become like PCI to him.
The learning curve was so big for him, actually.
Yes.
So when I asked him about his complication rate, he was to think about quite a lot to find when was the last patient he had a complication. That's the success rate, I think.
Yeah, success rate are more than how to say, more than 98%. But you have only 2%, let's say 1 to 2% of complication. But it's not the complication the problem. The problem is when you cannot deal with complication. Sometimes you have vascular damage or need to capture your valve that embolized and put another valve. Sometimes you have a procedure with 2 valves implanted in the patient. and the patient is good. So, the problem is not complication. The problem is when you cannot deal with complication. And where you cannot deal with complication, I think it's more the annulus rupture and stroke. The problem with stroke, that is unpredictable. You can do everything. You can change your TAVI access because you don't want to have the arch have embolization from the arch. You can do a lot of heparin. You can do everything, but even though in some patients they will have a stroke. So when you do TAVI and you have very good results, and with a stroke after the procedure, I think this definitely is my nightmare with TAVI.
What's the long-term results of this? All these valves are tissue valves. What are the durability? Are they comparable to the surgical tissue valve long-term?
Yes, for long-term now we have trials that give us good results for more than 7 years. 7 years durability, but you know we began the experience with a high-risk patient that the contraindicated for surgery, and I think we have to wait for intermediate and low-risk trial and to have the durability of these patients included in these trials. You know, for SAPIEN 3 they will follow the patient for 10 years. So I think we need good trials with patient referred with intermediate and low risk to check durability.
There's
one more question, Doctor. Yeah.
Is balloon valvuloplasty needed in all cases? Free?
No, we don't. No, we don't know. We don't do more. We don't do balloon valvuloplasty previously to the implantation. We can do it once only if the valve is very, very calcified and you are using balloon expandable. Because if you are doing balloon expandable and the valve couldn't cross the native valve, it would be very difficult. Sometimes you have to have another wire and do a little another valvuloplasty. But if it's very, very calcified, do balloon valvuloplasty before. Then you can do it always without balloon valvuloplasty.
I think we'll have one last question, which is what is a pre-existing aortic regurgitation will decide about, because a patient has got aortic stenosis with an aortic regurgitation. Will that influence a TAVI decision?
No, of course not. It will. You usually in this patient they have large annulus. Patients that have aortic regurg with aortic stenosis have large annulus, and in this case I prefer the balloon expandable.
Do you use any carotid filters for stroke prevention?
No.
I think
no filter, because every time you will use them, you have you could have complication when you use them. So if you are using them to avoid stroke and have stroke when you are putting them in the carotid, it would be difficult to support.
And one more question. What's your experience about...
It was the last question.
I think this is the last question.
One more last question.
Yeah, we won't leave you. We won't leave you.
Dr. Balakumran wants to know what's the transapical, but you need to know, Dr. Balakumran, Dr. Ghostini has done maximum number of carotid, because his next choice...
it's one of the highest experience. Yeah. So
do you want to say something about that before we conclude the session?
The difference between transcarotid and transapical?
Yeah. I know what he says is what's your experience about transapical, which we don't do, I guess, which will be carotid, I guess.
Yeah. Okay. So I will show you. I will show you, if you have 2 minutes. I will show you our experience with transapical. And let me 2 seconds. Well, before we begin the transcarotid, we've done a lot of transapical. Okay, we had 20% of our procedure in 2012 done by transapical approach, and now we moved for transcarotid. Because transcarotid is more, done under general anesthesia. The chest is not open. Even you don't have lateral thoracotomy. So, everything is simple with carotid. It would be very difficult if you have, transapical, I'm sorry. Transapical is, oops. I will show you just one slide with the experience that we've done with. Oops. Yeah. Do you see the slide?
Yeah.
Yeah.
Yes. We checked. We published this in 2014, from November 28 until March 2012. You see, we have 80% of our procedure were transfemoral. And 20% of our procedure were transapical. Okay? And from 2012 to 2014, we changed everything and we've done, no more transapical. So, I know that in Germany, they are very, they do a lot of transapical. But probably because in Germany, TAVI are more done by surgeon than by cardiac catheterization,
Yeah.
So if you have good surgeon, cardiac surgeon, they should do good work with transcarotid approach. It's very simple. The patient will recover very quickly.
And you do it local. That's the advantage, isn't it?
Yes, all our transfemoral procedure are done under local anesthesia and sometimes hypnosis. And if they want, we can listen to the opera at the same time.
Thank you, Dr. Ghostini. It's been wonderful having you, and thank you for your time. And
yes.
We'll see you again in more meetings because this is the start of the webinar series.
Yeah.
So we'll
thank you, guys. Yes.
We'll save some more questions for next time. Thank you.
No more last question?
Thank you.
No. That's the last time.
Okay. Have a good webinar and protect yourself from COVID. Okay.
Thank you.
Thank you very much.
Thank you. So, bye-bye.
Now, we will go on with our next session. We had a bit long one, but I think next one will be more interesting as well because it's about OCT basics, and our Vijay Kumar is here. He will explain.